I'm going to talk about something on a DSEK, which is become very, very common for most corneal disease which affects the endothelium, and CHED is one of them. Though it's rare, but if you are in a referral centers like ours, we do see significant number of cases which would require a surgery or a treatment to maintain the clarity of cornea throughout the life. You can imagine this child is going to live for the next 70 years. How many keratoplasty this child will require to maintain the clarity? In that way, I think DSEK is the right option for such cases where we can replicate this surgery many, many times without compromising the anatomy of the eye, that is the anterior part of the cornea. And we all know definitive treatment for a CHED would be keratoplasty, and why not DSEK? So this question why DSEK I'm talking about today is it has the advantage of endothelial keratoplasty, as you all know, and it takes away the disadvantage of a penetrating graft in most cases, which requires a lot of other inputs in these cases. So this is one study where they compared ultra-thin DSEK with DMEK, and the results are comparable, especially in cases with a CHED, which has so many other issues of anatomical considerations. Therefore, I think DSEK, which is well-established surgery for all of us, definitely going to give an advantage in this difficult situation, while DMEK still is a challenging situation for a hazy corneas, which is always there with CHED patients. Now, this is our publication, Dr. Namrata has published this, our retrospective series of cases where we have done a DSEK in CHED patients. In 48 eyes, you know that we had long series of follow-up, and around 93% of grafts survived that long. That's one of the best results which can happen in any disorder of cornea, especially with the endothelial disease. Around 36% cell loss. Rebubbling rate is almost similar to any other studies published in the literature, around 10%. Some rare complications are there in these cases. These are various surgical challenges which may face because of phakic eyes, small anterior chamber, clear lens in these cases, and you have to maintain the distance from the anterior lens capsule so they don't damage it, otherwise cataract will form. Glaucoma may be associated in most of these cases. The surgical aspect has to be little modified than a normal DSEK case in these cases. If you see these hazy cornea like this, if you have IOCT attachment microscopes, that makes your life very, very simple. In fact, we have been talking everywhere, wherever we go in our conferences, people who practice cornea, they must have an IOCT microscope with them. Just to highlight the one surgical video of one of my young patient, I think this was a patient around a 2-year-old child. I make a pocket for every incisions, which makes the incision much better. Do a gentle scoring of desmids in the periphery, which is around 7 millimeter in these cases, because the graft size is definitely going to be smaller than the normal DSEK which we do for a pseudophakic bullous keratopathy here. The flow here should be maintained slow. You can know, the retina colleagues will know this is a cannula. It gives a very small flow, a small incision. Under pilocarpinized pupil, you have to scrape the desmids here. So this is one way of achieving the removal of desmid in a CHED patients. Otherwise, sometimes you have very difficult to see anything coming out. Most cases like that, we might do a DSEK in an unscraped desmids also. You can see in this particular case, the desmid could be scraped out entirely, and this patient will definitely have a better outcome as such. Towards the end, now I'll open the main incision after completing my scoring, and surgery becomes very simple after that. That DSEK lenticule which has been prepared, pulled inside the anterior chamber. Now I'll push the fluid from this side port, and this will open the entire graft. Subsequently, we can inject the bubble to force this graft to get attached to the bare stroma of this patient. So this is looks very, very simple because this cornea was little clearer. Otherwise, sometimes very difficult to see what is happening inside the eye is also very difficult in the CHED patients. You can see towards the end, you can see in IOCT, the graft is well attached, because this is very important to realize that these patients are pediatric patients. You can't take these patients every day to the OR to see what has happened. If you have an OCT, you can see your graft attachment is complete on the table as such. The next issue is how do we make ultra-thin DSEK lenticule? So if you see this particular image here, the first thing is to measure the thickness with IOCT microscopes. Accordingly, select the keratome head. So this cornea was around 600 microns. I have selected 500 micron keratome in this particular case, which should give around 120 micron thickness, which is ultra-thin DSEK lenticule. So I would consider automated DSEK lenticule making is necessary for making ultra-thin DSEKs. You can see a beautifully thin lenticule which has been created. If I lift the anterior cap, you'll see the lenticule is around 100 micron in this particular case. So anything less than 120 microns is ultra-thin DSEK lenticule. The other option is to do a double pass techniques. If you have a very thick cornea, first I have taken 400 micron thickness blade, which gives around 300 micron corneal tissue. You can see around 300 micron tissue is there. The next pass can be created from the other side so that I can get around 80 to 100 micron thickness. So this is the second pass which I am doing. So this will give us a thickness which is around 80 to 100 microns, which is ultra thin. So this type of achievement is critical for getting a good outcome for all patients for subsequent surgeries to become more fruitful. There are certain important signs which will make things clear. Your graft is well oriented in the anterior chamber. Double ring sign and acute bubble sign gives you an idea that your graft is well placed in the anterior chamber, because hazy cornea, difficult to see what has happened. So this is one of my patients. After 1 year, you can see the cornea is absolutely clear, slit section, and you can see this DSEK lenticule is less than 50 microns at 1 year. So this is ultra thin DSEK. This is another patient after 2 years, clear graft. This is another patient after 1 year, graft is very clear. So this was a case which came to us at the age of 18 years. You can see a thick stoma and epithelial edema in these cases. This is after 2 years of surgery. The graft looks clear, but the host cornea still looks little hazy. But despite that, the patient could get a good vision subsequently. So you have to have patience to see these patients getting cleared subsequently. Outcome-wise, these are various series you have in the literature. Also, the largest series of cases from RP Center, and follow-up is also more than 2 years in mean follow-up in these cases. The rebubbling rate is almost similar in all cases. Most importantly, the graft failure is less than 10%, which is very significant outcome in these difficult cases as such. Glaucoma, cataract can be associated in these cases. In a post-op period, most pediatric patients would require a EUA to examine these patients carefully. Always rule out glaucoma in these cases, and always see fundus and do a refraction if graft is clear. Treat amblyopia in these patients. So this is one very, very important publication. We also have a similar view. If your patient comes early, in an early age of presentation, the graft success is much better in these cases, and visual acuity recovery is also better, and amblyopia treatment can be done. If patient comes late, the graft becomes difficult in terms of taking the load of cornea, which may be more than 1,000 thickness, and sometimes clarity is challenging in these cases. The early age of presentation, timely surgery will take care of a corneal thickness and haziness and improve the quality of vision for these patients. Being a phakic patient, always look for a cataract formation, which may be because of steroid-induced or a trauma which can happen in these patients. To summarize, I think ultra-thin DSEK gives the advantage of simple surgery of DSEK and advantage of DMEK in terms of clarity of vision, and recovery of cornea happens within a 6 to 8 weeks in these cases. And final visual recovery is based on a corneal clarity as well as the refractive correction for these patients. So I would say if you are experienced DSEK surgeon, shift to ultra-thin DSEK for these cases with hazy corneas, and we'll have a definitely better outcome in these cases also. Thank you for your kind listening.
Thank you, sir. So concluding this session, the last talk is by Dr. Namrata. And she'll be speaking on intraoperative OCT-guided DMEK.
Thank you, Jaya. At the outset, I would like to thank Ajanta Pharma for this summit, ophthalmology summit. And